Hello and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. We encourage you to ask questions and share ideas to help the community learn and grow. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. Today, we are honored to welcome Dr. David Yousem for a case review entitled Sinonasal Case Review Vitamin C and D. Dr. Yousem is a neuroradiologist and professor of radiology at the Johns Hopkins University School of Medicine. He's the author of more than 350 scientific papers and several popular books in radiology, including Neuroradiology, The Requisites, and is the series editor of the Case Review series. He has served as the president of ASNR and was awarded the Outstanding Educator Award from the RSNA. We are grateful to Dr. Yousem for her support of MRI Online and for serving as our neuroimaging subspecialty advisor. At the end of the case review, please join him in a Q&A session where he'll address questions you may have on today's topic. And please remember to use that Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we're ready to begin today's case review. Dr. Yousem, take it from here.
Thank you very much. So today we are going to go through some multiple choice questions on sinonasal imaging unknown cases. I'd like to have as much participation as I can from the standpoint of the polling and the multiple choice answers, and we'll see how you do. So let's get going. Just as a reminder, my mnemonic, vitamin C and D, refers to vascular, infectious, traumatic, acquired, metabolic, idiopathic, neoplastic, congenital, and drugs. And those are the general categories of disease that we see across the full spectrum of pathology in the body. And in the sinonasal cavity, obviously, it's going to be dominated by infectious etiologies, inflammatory etiologies, and neoplastic etiologies. So let's begin. And my disclosures, I do have several books published by Elsevier for which I receive royalties. I do medical legal expert witness work, and I am one of the consultants and speakers for MRI Online or Medality. And yes, the 5th edition of Neuroradiology, the core requisites, is coming out in March. So go to the Elsevier site or Amazon, wherever you want. All right, here's our first case. So what we got here is the sagittal T1 weighted MR, the axial T2 weighted MR, a post-gadolinium enhanced scan here, and this is the FLAIR scan. So T1, axial T2, FLAIR, and post-gadolinium, this is with fat suppression, T1 weighted scan. So what is the most likely diagnosis given these imaging findings? Do you think this is most likely a squamous cell carcinoma, a mucus retention cyst, allergic fungal sinusitis, inverted papilloma, or a Schneiderian polyp? So looking at the pathology that's being demonstrated, what do you think the most likely diagnosis is? If you think it's squamous cell carcinoma, answer number 1. If you think it's a mucus retention cyst, answer number 2. If you think it's allergic fungal sinusitis, answer number 3. For inverted papilloma, you're going to put number 4. And for a Schneiderian polyp, put number 5. So we're got about 200 people on board, and we're going to see what the audience recommends. So let's share results. And it looks like 68% of the people answered allergic fungal sinusitis, and indeed that is the correct answer. You notice that on the T1 weighted scan, we have areas within the paranasal sinuses that are bright on T1 as well as dark on T1. On T2, the predominant abnormality here is dark on T2 as well as flare. In fact, you might think that this is aerated sinus just looking at the T2. And then we get to the post-GAD T1 and we see, no, that's not aeration. That's very inspissated secretions or allergic fungal mucin that is causing the very low signal on the T2 weighted scan. And you see also that the ethmoid sinus is opacified. So remember that the signal intensity of the secretions in the paranasal sinuses is dependent in part on the protein concentration. And this was beautiful work that was done by the late Peter Somm in the 1980s, in which he actually got the ENT doctors to aspirate sinus secretions and then measure the protein concentration. And what he showed was that this is signal intensity, this is the T1 and this is the T2. When you have low protein concentration, effectively just fluid, it's going to be dark on T1 and bright on T2. However, as the protein concentration increases, you notice the first thing that happens is that the T1 becomes bright. This is the iso-intense line here, becomes bright. So you have a period where it's bright on T1 and bright on T2. But as those secretions get more and more mucinous and less watery, you come to a point where it's bright on T1, but now it's dark on T2. And when it becomes a concretion, effectively like a calcification, it's dark on T1 and T2. So these are the graphs that you should know about protein concentration. And this also will pertain to things like craniopharyngiomas or pineal region cysts or other things that have high protein content, like colloid cysts, for example. The things that are hyperdense on CT but dark on T2 include blood products. It's just like that. Hyperproteinaceous secretions, fungus. You may see that with osteomas or odontogenic lesions, and indeed melanin, which may be bright on T1 and dark on T2 from the melanin, is often hyperdense on CT, in part maybe because of it may be hemorrhagic as well. So this was a case of allergic fungal sinusitis, which is not an aggressive, invasive type of fungal sinusitis. Remember that we have 5 different varieties. We have our non-invasive fungus ball or mycetoma. It's usually in the maxillary sinus. We have our non-invasive allergic fungal sinusitis with the eosinophilia and the mucin. We have the acute invasive fungal sinusitis. Those are usually the patients who have diabetic ketoacidosis at presentation and are immune compromised, and they may have mucor or aspergillus. Then we have the chronic invasive sinusitis, long-standing patients who have chronic rhinosinusitis. And then this unusual chronic granulomatous invasive fungal sinusitis that is not usually seen in America, but more commonly in Africa or Southeast Asia. Here's another example on CT of a patient who had allergic fungal sinusitis, and you see the hyperdensity to those secretions, and there is some bony dehiscence because of effectively like polyps, it's remodeling the bone. The 5 criteria for allergic fungal sinusitis: type 1 hypersensitivity, often seen with the eosinophilia, nasal polyposis, CT findings of opacification, eosinophilic mucin, and a positive fungal stain without demonstration of invasion. Here, on the other hand, on a MRI with bright on T1, this is it turned out to be a mycetoma, fungus ball in the right maxillary antrum, opacifying it. This was one of the cases that I saw back when I was a resident, in which the patient had severe fungal invasive sinusitis with mucormycosis. And what you're seeing on this post-gadolinium T1 weighted scan is opacification of the right cavernous sinus, but absence of opacification in the left cavernous sinus. And if you look at the carotid artery here, faintly seen, it's narrower than the normal right side. It's got a little irregular margin. So this patient had fungal sinusitis with invasion of the cavernous sinus and thrombosis of the cavernous sinus associated with vasculitis. And the next scan showed MCA infarction secondary to the left internal carotid artery vasculitis from the invasive mucormycosis. All right, next case, case number 2. Let's move on. Here's the CT scan axial original data, sagittal reconstruction, MR T1 post-GAD, MR axial T1 post-GAD. So I'll give you a moment to look over the case. CT and MR with GAD. Most likely diagnosis for this entity: is this a mucocele? Is this pot puffy tumor? Is this a dermoid? Is this nasal glioma? or is this a sebaceous cyst? So the most likely diagnosis here, if you think it's a mucocele, answer number 1. If you think it's pot puffy tumor, number 2. If you think it's a dermoid, answer number 3. If you think it's nasal glioma, number 4, or a sebaceous cyst, number 5. So let's see how the audience is doing here. And I think we can end the poll because there's an overwhelming, let's share that results, overwhelming support for pot puffy tumor, and that is indeed correct. You have a patient who has a frontal sinusitis with opacification. There's a little divot here out of the frontal sinus where the infection has entered the soft tissues of the forehead. And obviously, this pot puffy tumor was thought to initially be a tumor because it was presenting as a soft tissue mass under the skin. And let me give you a little history here. All right, pot puffy tumor, forehead edema resulting from osteomyelitis of the frontal bone associated with a subperiosteal abscess, first described by Sir Percival Pott in 1768. Let me tell you, they did not have CT scans back then. And that's why he thought it was a tumor rather than the spread of infection from the frontal sinus. And obviously, when he went to cut it open and got that purulent stuff coming out. So you have rubor, tumor, calor, and dolor. So redness, swelling, warmth, and the tumor in this case is the observable swelling of the forehead rather than to any neoplasm, and it's a complication of frontal sinusitis. So pot puffy tumor. We often call it Pott's puffy tumor, but the gentleman's name was Sir Percival Pott. Frontal sinusitis is an entity that may be associated with the infection going superficially and creating a pot puffy tumor, but it could actually also extend intracranially where you may have an epidural abscess develop from the infected frontal sinusitis. You see that here. If this collection dissects the sinus off of the periosteum of the frontal bone, it may actually cross the midline. And any collection that's crossing the midline, we assume is going to be an epidural abscess or epidural hematoma, as the case may be with trauma. So you may also see findings of meningitis. So look at the FLAIR scan, look at the CSF. Is the CSF still suppressed on the FLAIR scan? Or if it's not suppressed, that might imply that there's meningitis associated with it. Obviously, with this type of proximity to the superior sagittal sinus, you may get sinus thrombosis and then have a superimposed venous infarction on top of the infection, on top of the sinusitis, for example. Okay, we're moving on to the next case. This patient had previously had a medial antrostomy for inflammatory disease. And what you're seeing is this is the sagittal cyst T2 weighted scan. This is the postgadolinium T1 weighted scan. This is the axial T2 weighted scan. And you can see that we're going through this abnormality. And then this is the ADC map of the lesion. So patient who had previously had surgery, and you can see that the lesion in question here that we're looking at is this area here. The most ominous feature of this lesion is what? Is it the dark signal on T2 weighted imaging? Is it the fact that it enhances? Is it the low ADC? Is it the eroded bone? Or is it being bright on T2 weighted scan? So on the imaging features of this lesion, which one kind of bothers you most? Is it the dark signal on T2 weighted imaging? Is it the presence of enhancing tissue? Is it low on ADC? Is it eroded bone? Or is it bright on the T2 weighted scan? Which of these is the most ominous feature of this lesion? All right, T2, postgad, T2 axial, ADC map. All right, we got over 100 responses, so let's see what people said. Okay, so the answer to the question by the group is low ADC, and I would agree with that. The reason why I would agree with that is dark 1T2, as you know, we just saw a case of allergic fungal sinusitis that can occur with inspissated secretions. It can occur with fungal sinusitis. It can occur with osteomas. I gave you all of those differential diagnoses. Enhancement. So enhancement is important, and solid enhancement is going to be a pretty good indicator that this is neoplastic as opposed to an inflammatory process. So the fact that this tissue shows enhancement is an ominous finding. Low ADC, yes. However, remember that just as epidermoids may have low ADC, and it's not necessarily because of hypercellular tumor, it's in part because of the concentration of protein in the lesion or the content of the lesion. You may see inspissated secretions and things with high protein that will have restricted diffusion. Eroded bone, definitely, but a lot of benign tumor, benign conditions, including mucoceles, including polyps, including osteomas, those things can erode the bone and yet be a benign condition. Bright on T2, usually that's reassuring. So that would be the least. So given all of these findings, what do you think the most likely diagnosis here is? Is this a squamous cell carcinoma? Is this an inverted papilloma? Is this melanoma? Is it lymphoma, or is it fungus? So our lesion is here, relatively dark on the T2, showing contrast enhancement. Dark on T2, a little bit of obstructed secretions, and low on ADC map. What do you think the most likely diagnosis is? Is it squamous cell carcinoma? Is it inverted papilloma? Is it melanoma? Is it lymphoma or fungus? So number 1 for squamous cell carcinoma, number 2 for inverted papilloma, 3 for melanoma, 4 for lymphoma, and 5 that there's a fungus among us. Let's see what people say here. So let's share some results, and we have a mixture of different suggestions, including squamous cell carcinoma, lymphoma, inverted papilloma, not so much melanoma, and not so much fungus. So I think that's reasonable. All three, the squamous cell carcinoma, inverted papilloma, and lymphoma, may look this way. If you're going with the most likely diagnosis, by the numbers, the most likely cancer of the paranasal sinuses is squamous cell carcinoma. So that would be the best diagnosis here. It's not a particularly good location for an inverted papilloma, which usually occurs along the common wall between the maxillary sinus and the nasal cavity, or along the septum pellucidum. This area, which is effectively in the ethmoid sinus, is not the best location for an inverted papilloma, not classic. So our answers are low ADC and squamous cell carcinoma by numbers. It looks like there's some, I got some chat things. Let's see. No, not for me. Okay. No questions at the moment. Question and answer. What is a Schneiderian polyp? Schneiderian polyps are types of polyps that are included with inverted papilloma, and it refers to the histopathologic features. And I'll move forward because they ask about the answers. All right. So here is a graph that you see from head and neck surgery and oncology, Jatin Shah, who's from Memorial Sloan Kettering. And you notice that the most common of the cancers of the nasal cavity and paranasal sinuses is indeed squamous cell carcinoma. And then we have this kind of other category, which are undifferentiated cancers. We have melanoma, which is the pink here, minor salivary gland tumors, etc. And the sinonasal undifferentiated carcinoma, one of the more aggressive of the sinonasal cancers. All of these kind of look alike except for melanoma, which hopefully you'll see as bright on T1 if it has enough melanin content within it. Esthesioneuroblastomas are the ones that are usually in the upper nasal cavity and ethmoid sinus and cribriform plate that grow most frequently intracranially, and the characteristic feature of that is the peripheral cyst associated with the esthesio. That happens with other cancers, but the highest rate is with esthesioneuroblastomas, or what we sometimes use the term olfactory neuroblastomas. Here's the 80% rule. 80% of sinus cancers occur in the maxillary antrum. Of those, 80% are squamous cell carcinoma. Of those, 80% erode bone, and 80% have a history of chronic sinusitis. Moving on. Next case. CT scan, axial raw data, coronal reconstruction. Least likely diagnosis. Number 1, granulomatous polyangiitis. Number 2, fungal sinusitis. Number 3, cocaine abuser. Number 4, syphilis. Number 5, Klebsiella. So for this imaging finding that you're seeing, what is the least likely diagnosis? If you think it's granulomatous polyangiitis, GPA, number 1. If you think it's fungal sinusitis, put number 2. If you think it's cocaine abuser, put number 3. If you think it's syphilis, put number 4. And if you think it's Klebsiella, put number 5. Okay. So let's share the results. And the correct answer here is fungal sinusitis, which I guess is the second most common answer here. Klebsiella is one of the bacteria that will collapse your nasal septum. So the finding here is nasal septal perforation and erosion, and you have all that soft tissue. So in yesteryear, we would often use the term Wegener's, but now we're using granulomatous polyangiitis. That's a pretty frequent cause of demonstration of sinus involvement by Wegener's. Fungal sinusitis doesn't often cause septal perforation. Cocaine abuser in East Baltimore at Johns Hopkins is probably the most common thing, and we probably have around a 10 to 20% rate of patients that you're reading their trauma head CT or motor vehicle collision and you see nasal septal perforation. So cocaine or other drugs. Syphilis, saddle nose deformity associated with syphilis and leprosy, those are known causes as well. So the correct answer was fungal sinusitis. This is another one of the entities that can lead to a granulomatous sinusitis as well as inflammation in the orbit. So Wegener's also may have inflammation in the orbit associated with a nasal septal perforation. When you put those two together, you will come up with the granulomatous polyangiitis as well as sarcoidosis as another of the etiologies. It can occur after trauma. It can occur with a nasal septal hematoma that erodes the bone. So there's lots of differential diagnosis for nasal septal perforation. Here I have a relatively large listing. Remember, I talk about vitamin C and D, vascular, infectious, traumatic, acquired, metabolic, idiopathic, neoplastic, and drug. And here we have our trauma causes. We have an inflammatory causes, lots of those collagen vascular disease, infectious causes, syphilis, etc. You notice that Klebsiella is not listed here, but it is one. It does mention fungal, but that's the aggressive fungal infections. Neoplasms, carcinoma, T-cell lymphomas, and then all these toxic etiologies. All right. I want to make a point here that on this case, you saw that there was some dehiscence along the lamina papyracea. And when I am reading a sinus CT where I know the patient is going to surgery or is about or has gone to surgery, there's 4 critical areas of dehiscence that you might want to look at and put in your reports. The 4 critical areas of dehiscence are the lamina papyracea, as you see here, along the medial orbital wall, because if it's dehiscent and the surgeon is going in to clean up that ethmoid sinus, there is that possibility that they would perforate into the orbit and lead to an orbital hematoma. The second is the cribriform plate. Here you see a defect in the cribriform plate. In fact, this patient actually has a meningocele that's extending intracranially. So post-op, if they take down the middle turbinate, remember that the middle turbinate has a connection to the cribriform plate as well as to the lateral orbital wall. And if they're removing the middle turbinate, there's a chance that in that removal, they lead to a cribriform plate or a lamina papyracea, basal lamella injury to the medial orbital wall or the skull base. And that potentially could be a source of CSF leakage, but it also, if it's dehiscent, could lead to the next time they operate, potential intracranial perforation. The optic nerve and canal. It's interesting how often you will see that the optic nerve at the optic canal has no bone around it in the sphenoid sinus and or posterior ethmoid region, depending upon whether you have a nodie cell. So I often will comment on the dehiscence of the wall of the optic nerve if they are contemplating sphenoethmoidal surgery. And more, that's usually associated with sella tumors or pituitary adenoma resection, for example. And then finally, the carotid canal. So here we have the dehiscent carotid canal. You can see the enhancing carotid artery. There's no bone overlying it. Again, at our institution, they will do a 3D 3D data set of the paranasal sinuses prior to pituitary adenoma surgery because they want to know where the carotid arteries are with the potential for injury if they're doing an endoscopic removal of a pituitary adenoma. So they want to see the walls of the carotid arteries and actually then also the tumor's relationship to the carotid artery. So these are the 4 things you might want to think about adding to your report when you look at a sinus case that's either about to be operated on or has previously been operated. Okay, let's move on. Next case, most likely diagnosis. CT scan, axial and coronal reconstruction. Most likely diagnosis. Is this most likely an intracoanal polyp? Is this most likely a mucus retention cyst? Is this most likely allergic fungal sinusitis? Is it inverted papilloma or is it the old Schneiderian polyp once again? So if you think it's an intracoanal polyp, you'll put number 1. If you think it's a mucus retention cyst, you'll put number 2. If you think it's allergic fungal sinusitis, number 3. If you think it's an inverted papilloma, put number 4. And if you think it's a Schneiderian polyp, put number 5. All right, tricky case. So most people put intracoanal polyp, and that is not the correct answer, although this looks exactly like an intracoanal polyp. So why is this not an intracoanal polyp? The density of this lesion is what should give you pause that this is not like a typical polyps. Polyps generally are lower density on the CT scan. They may even be fluid density. Remember that mucus retention cysts and polyps of the maxillary antrum often are very liquidy and low density. The key here to this case was that this looks like hyperdense. Here's the mucosa here peripherally that is less dense. This was histopathologically an inverted papilloma. So that was the second most common answer. So very good to those people. The intracoanal polyp, as you see here, more likely to be a low density lesion, but it does go through the ostium of the maxillary sinus. Usually we say it's the inferior ostium or the accessory ostium, but it does then project into the nasal cavity. That's sort of the choanal portion of it. And then it can even project back into the nasopharyngeal airway posteriorly. So from here, it may project posteriorly as a nasopharyngeal soft tissue mass. In this case, again, look for a lower density to suggest that it's intracoanal polyp as opposed to the inverted papilloma. Here is an inverted papilloma. As I mentioned, it usually forms along the common wall of the maxillary antrum and the nasal cavity. And from there, it can grow into the maxillary sinus or into the nasal cavity or both. Here you see a little bit more growth into the nasal cavity than into the maxillary antrum. It will show solid enhancement, not peripheral enhancement. Peripheral enhancement more common with the intracoanal polyp, not solid enhancement. And you can see that intermediate signal intensity on the T2 weighted scan. There are 2 features of inverted papilloma that we say are relatively pathognomonic to suggest that specific diagnosis. One is this little bony bar upon which the tumor may be fixed. So if you see that hyperostotic bone and the tumor seems to be centered around that hyperostotic area, that would be an indicator for an inverted papilloma. Again, usually the common wall between the maxillary antrum and the nasal cavity or along the midline nasal septum. The other feature that we say is relatively pathognomonic for a inverted papilloma is this cerebriform look to it. It has almost a look like gyri and sulci within it that you see here, or gray and white matter. And you can see the enhancement as you see here. Maybe this is the cortex and this is the underlying white matter. That imaging pattern is more typical of inverted papilloma than anything else. Now, that said, we always worry with inverted papilloma because there is that high rate of concurrence of squamous cell carcinoma at about 15%. So these tumors are resected in their entirety and with a margin because of the worry that there may be underlying squamous cell carcinoma. Unfortunately, the squamous cell carcinoma has the same relative imaging features as that of the inverted papilloma. So it's not as if you can look at this and say, oh, this is, this one has squamous cell versus this one that does not. Okay, next case, question 6, most likely diagnosis. So we have axial CT and a coronal CT. You see that contrast was administered here. What do we got here? Do we have orbital cellulitis, periorbital cellulitis, post-septal cellulitis, subperiosteal abscess, or none of the above? So this case, what are we looking at? Are we looking at orbital cellulitis? Are we looking at periorbital cellulitis? Are we looking at post-septal cellulitis? Are we looking at a subperiosteal abscess, or none of the above? All right, so we're moving right along here. All right, let's see. So 66% of people put subperiosteal abscess, and that is ding, 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 the correct answer. Let's go back to the original images. So most of the cases of inflammation of the orbit occur secondary to things around the lids, bites, or lacrimal problems, etc., cellulitic things in the forehead, etc., and sinusitis. And with sinusitis, it's most commonly the ethmoid sinus that has that ability to spread to the orbit. Why is that so? You see this a lot with kids because there are areas of dehiscence along the lateral wall of the ethmoid sinus. And even in adults, it occurs. And if you think of the lamina papyracea, the medial orbital wall of the orbit being that thin that we would call it papyracea, paper thin, you might expect that along those channels that have vessels going into it, that you might have a route for spread from ethmoid sinusitis to the orbit. Additionally, remember that we have the anterior ethmoid artery and the posterior ethmoid artery that enter that go between the orbit and the ethmoid sinus through those areas of vascular channels that communicate between the sinus and the orbit. So here we have this collection, and you notice that it's displacing the medial rectus muscle. The superior oblique muscle is enlarged compared to the normal superior oblique muscle, and we have this low density collection here, and that is accounting for here. This is probably the medial rectus muscle, and this is the collection. With these collections, we call them subperiosteal abscesses even if we do not see peripheral enhancement. So this is one of the locations that we would still use the term abscess, even though on the post-contrast scan, you don't see a walled off collection with peripheral enhancement. Most of the time nowadays, these lesions are treated with intravenous antibiotics and close observation in the hospital. And if it does not quickly resolve, then they usually are going to treat the sinus disease endoscopically and try to address the primary infection that's causing this problem with the sinus disease. When I was a resident and before endoscopic sinus surgery was so popular, they would go medially along here under the periosteum and try to drain these surgically. But that's not, this is no longer primarily a surgical orbital procedure. It's let's give high dose intravenous antibiotics, see how the patient does. If they improve, continuing them as an outpatient on oral antibiotics. If they don't improve rapidly, then consider endoscopic sinus surgery to reduce the infection in the ethmoid sinus. Generally, the ENT docs don't like operating when there's active acute sinusitis because of the potential for spread by virtue of their surgical procedure. Okay, so this was a subperiosteal abscess. Note that post-septal cellulitis and orbital cellulitis are the same entity, the inflammation that gets into the orbit. Here's an example post-septal cellulitis on the left side with infiltration of the orbital fat. You notice that the orbital fat on the left side is more dense than the orbital fat on the right side. There's all kinds of episcleritis that's happening here as well. Here's a collection that you see superiorly, a subperiosteal abscess. And this orbital septum, all the diagrams always show it on a sagittal scan. What we usually want to see it is in an axial plane, and this is the demonstration of the orbital septum, in this case, inflammation of the orbital septum, still called periorbital cellulitis. Here we have the collection of the subperiosteal abscess from the ethmoid sinusitis. But here's the normal septal tissues that you see here and here, orbital septum. There is a classification for the degrees of orbital infection. We have the Chandler classification. Number 1 is preseptal cellulitis, what we call the periorbital cellulitis, postseptal cellulitis or orbital cellulitis, a subperiosteal abscess. So this was a case of grade 3 Chandler classification. 4 is actual orbital abscess where the lesion is in the intraconal space, for example. And then as an example of that mucormycosis case, we have cavernous sinus inflammation and/or thrombophlebitis. So I'm just going to refer to the question here. In your practice, do you proceed to MR with contrast for cases of suspected inverted papilloma on unenhanced CT or inject contrast on CT? We're going with MRI, mainly because there is that potential for perineural spread of tumor back through the pterygopalatine fossa, as well as intracranial spread. And both of those are much better seen on post-GAD MR than with CT. So it's pretty rare for us to do a contrast enhanced CT for neoplasms or for suspected intracranial spread of an infection. Can you have orbital subperiosteal abscess without concurrent orbital cellulitis? In general, what you see is the infiltration and edema of the intraconal fat associated with the subperiosteal abscess. So most of the time you get this infiltration of the fat. So it is, it is with concurrent orbital cellulitis, but with the Chandler classification, we would call it grade 3. All right, moving on to the next case. Here we have CIS imaging, T2 weighted high resolution imaging. This is the traditional coronal T2 weighted scan, post-GAD T1 sagittal scan, the axial T2 weighted imaging, and a post-GAD axial scan. So here we have a child, and we have T2 weighted imaging, high resolution, as well as post-gadolinium enhanced scans. What term should not be used for this lesion? Should not be used. Sincipital cephalocele, sphenoethmoidal cephalocele, meningocele, basal cephalocele, or none of the above. They're all good. So which of these is the inappropriate term for this lesion? Would it be sincipital cephalocele, sphenoethmoidal cephalocele, meningocele, basal cephalocele, or none of the above? They all apply to this lesion. Okay, so for this case, the key here is the difference between sincipital and basal. And the distinction is that the basal cephaloceles, obviously base of the skull, are generally invisible to the naked eye, to observation externally. Sincipital cephaloceles are ones that protrude beyond the skull such that you see them like the Pott's puffy tumor in the forehead, etc. And those are usually nasoethmoidal cephaloceles that will project through the foramen cecum or other pathways and project as a visible to the naked eye lesion. So that's sincipital as opposed to basal where it's invisible to you. So the correct answer here is that this is not a sincipital. No one would be able to tell what's going on despite the huge size of this lesion. And this was indeed a congenital cephalocele. Now the term cephalocele is kind of a indistinct, let's say. Usually we want to know whether the cephalocele contains meninges and fluid and or brain tissue. So depending upon whether you think this is purely meninges and fluid, you might use the term meningocele. If you think that there is indeed brain tissue, gray matter that's herniating through as well, you would use the term encephalocele. And if it's both the meninges, the fluid, and the brain tissue, we would use the term meningoencephalocele. The sloppy term or the lazy term would just be a cephalocele, in which you're not making that distinction. Now, let me just see whether I can go with the answer in the chat. Do you think that this cephalocele is congenital? If you think it's a congenital lesion, please answer yes in the chat. If you think that no, it's developmental or secondary to operative or trauma or other defect in the skull base, you would answer no. So just in the chat, you think this is congenital, say yes. If you think no, this is developmental or post-op or other cause, say no. So I'm looking in the chat and there's a lot of yeses, and that is indeed the correct answer. And one of the reasons why you know it's the correct answer is you may have noticed that there's missing portions of the splenium of the corpus callosum and the rostrum of the corpus callosum, identifying other congenital lesions that would suggest that this is a congenital encephalocele. Here is that CT scan where I was saying that there was absence of the cribriform plate, and look at this. Same patient, brain tissue and fluid and meninges assumed to be present, meningoencephalocele through the cribriform plate. This was a post-op patient who had a defect in the cribriform plate. This is a different patient, T1 weighted scan. Notice the puckering of the brain tissue towards this gap in the cribriform plate. Post-gadolinium, a little bit of enhancement of inflammatory change. This is actually the collection here and here, and where the collection is and the brain tissue is, you don't see the enhancement. So cephaloseals are a potential cause of CSF rhinorrhea. And as you see here, congenital, most common occipital associated with potentially are RNQRE3 malformations, post-op, post-trauma, sometimes idiopathic intracranial hypertension or pseudotumor cerebri may be associated with cephaloseals and meningoseals. That's why we look at the Meckel's cave region to see where that's associated. And some tumors also may cause CSF rhinorrhea and or a cephalocele. Okay, next case. CT scan, we have a coronal reconstruction from the axial data, and here's the axial scan. Most likely diagnosis here, is this a mucocele? Is this a mucus retention cyst? Is it silent sinus syndrome? Is it a hypoplastic maxillary antrum? Or is it a polyp? So given question number 8 is this a mucocele? If so, answer number 1. If you think it's a mucus retention cyst, we're going to answer number 2. If you think it's a silent sinus syndrome, number 3. Number 4 for hypoplastic maxillary sinus, and number 5, a polyp. So obviously the abnormality is in the left maxillary sinus. So let's see how the audience did on this case. All right, so 73% of y'all went with silent sinus syndrome, and that is indeed the correct answer. Why is this not just a hypoplastic maxillary sinus? Well, the imaging findings that you note, no doubt, is the puckering inward of the posterior outer wall of the maxillary sinus associated with the proliferation of the fat, and usually the floor of the orbit ipsilateral is depressed. And the common clinical finding here is enophthalmos, because everything's getting sucked in, and the globe actually becomes more inwardly displaced as the sinus is progressively decreasing in volume. So this is a source of enophthalmos and chronic sinusitis. This, on the other hand, is a patient who has a hypoplastic maxillary antrum. You notice in this case that the walls of the maxillary bone are actually thickened, associated with that hypoplastic maxillary antrum, and the floor of the orbit is not depressed. Here's another hypoplastic left maxillary antrum. Although this is bone window, you see that there's no proliferation of the fat that is associated with silent sinus syndrome. So silent sinus syndrome, usually you see complete opacification of the maxillary antrum. This was a little bit unusual in that it wasn't completely opacified. And we call it also the atelectatic sinus, as it kind of collapses on itself. And this is a manifestation of a chronic sinusitis with reduced pressure, leading to the walls collapsing inward and compensatory enlargement of the periantral fat. So silent sinus syndrome, usually with an opacified sinus. Okay, we're going to end on this one. It's sort of a classic case, and I wanted to show it in the session. Sagittal T1 weighted scan. This is a MRA that was performed because of the suspicion of an aneurysm. And this is a T2 weighted. This is actually a haste image because the patient was moving all over the place. But sagittal T1, MRA, and haste image. Is this most likely a mucocele? Is it a thrombosed aneurysm? Is it a schwannoma? Is it an epidermoid, or is it none of the above? So this lesion that we're seeing here, is this most likely a mucocele, a thrombosed aneurysm, a schwannoma, an epidermoid, or none of the above? Final case. So this is a petrous apex case, and the petrous apex is very much like the paranasal sinuses. So I thought it was okay for me to put it in here in a sinonasal talk. And petrous apex may be pneumatized, it may not be pneumatized. When it's pneumatized, it has the potential for petrous apicitis, for Petrus apex mucoceles and for an inflammatory reaction from bleeding that leads to a giant cell reaction and what we will call a cholesterol granuloma. So the correct answer here is none of the above. This is an example of a cholesterol granuloma, which is typically bright on T1 and maybe bright or dark on T2, depending upon the protein slash blood slash cholesterol content of it. You see here on the T1, it's in the Petrus apex. It expands the Petrus apex. So you see that here. The differential diagnosis is all of these. A mucocele of the Petrus apex could look just like this as well, and it's in the differential diagnosis. But cholesterol granulomas are much more common, and they're more heterogeneous, particularly on T2-weighted scanning. Most of the time with mucoceles, it's uniform signal intensity throughout the mucocele. Here you've got a little bright area, you got a little dark area, you got a little peripheral rim here of black. Is that hemosiderin or is that the bone? That's pretty typical of a cholesterol granuloma, not so much a mucocele. The reason why we have the MRA is to exclude a thrombosed aneurysm because your Petrus carotid artery courses right by here. And if you have a partially thrombosed aneurysm, you could have signal intensity that looks like blood products that will simulate a cholesterol granuloma, in this case, bright on T1, and it may be any signal intensity on the T2. Remember that thrombosed aneurysms may have that same layering effect, lamellated appearance that you can see with a cholesterol granuloma, and therefore could simulate that as well. Not likely to be a schwannoma, not in the Petrus apex. Epidermoid, so that's fair, right? Because they may be bright on T1s, the so-called white epidermoids. Most of them are dark on T1 and look kind of like dirty CSF on the flare. Most of them, however, are very bright on the T2. So this signal intensity would argue against an epidermoid of the Petrus apex. Epidermoid's can occur anywhere in these bones, so it's fair. Again, we would hopefully have a diffusion weighted scan, which might help us. Remember, however, that diffusion weighted scans in the presence of hemorrhage get very confusing to interpret because it looks bright and it may look like it has dark ADC, but it's really not. It's, blood products can do that. So in this case, the correct answer was none of the above because this was a cholesterol granuloma of the Petrus apex. So at this juncture, I'm happy to answer any and all questions about sinonasal imaging. I will put in a couple of plugs if you don't mind, and that is on our MRI Online Medality website, you have a case bank of 100 brain, 100 spine, and 100 head and neck cases with multiple choice questions that I've created as part of a effort to have MRI Online as one of your sites that you go to for case review, for board review. So if you are a little shaky in your neuro, come see me at Johns Hopkins, or alternatively go to MRI Online and they have material there. And they are building a larger and larger case bank with multiple choice questions to simulate the boards. And that's probably going to be appropriate for the next couple of years until we return to the oral board format with hot seat. So I'm going to go to the Q&A and see whether there are any questions for me. Okay. Questions and answers. Excellent. Question. Can susceptibility imaging help in the diagnosis of cholesterol granuloma? So most of the time, the blood products or the brightness is bright on T1. And bright on T1 is methemoglobin. And methemoglobin does not have proton relaxation enhancement unless it's in the intracellular form. So remember that in order to see susceptibility artifact, you have to have a difference on the signal intensity or the iron content inside the cell versus outside the cell or inside the brain versus in the extracellular space. So if the blood products are bright on T1 and bright on T2, that's the extracellular methemoglobin phase where you have proton-electron dipole-dipole interaction, but you do not have proton relaxation enhancement, which is the T2 shortening effect. So just a quick review of hemorrhage. Methemoglobin has proton electron dipole dipole interaction, which leads to T1 shortening, which makes it bright on a T1 weighted scan. Having blood intracellular and not extracellular leads to a bar magnet effect of the difference in charge between in the cell versus outside the cell, which leads to proton relaxation enhancement, which leads to T2 shortening. Once you have cellular lysis and it's extracellular methemoglobin, you no longer have proton relaxation enhancement. It's no longer dark on T2, and that's why it is bright on T2 from water content. So a little digression there into hemorrhage, but appropriate. Hey, what do Circle of Willis in your background stand for? COW, Circle of Willis, I think, and that was the MRA.
I think it's the picture of your cows behind you, Dr.
Oh, my
Yousem.
cows behind me. People want to know about my cows. Those are bulls, and this is my Picasso lithograph. And if you want to read about it, you can look up Picasso's bulls. But effectively, what I've interpreted this to be is that this is the progression of Picasso's artwork, going from initially charcoal drawings to realism, and then he converts to cubism over the course of time. This is more cubism. And then if you look over here, he got really minimalistic at the end and he just did line drawings. So this is the sort of the history of Picasso's interpretation and how he drew bulls. And this is Picasso's signature right here. So, okay. What to the cow in the background? Please, could you explain the features the surgeon needs to know in our sinonasal CT reports? Okay, so as I said, most of the time the surgeon needs to know whether or not there are any areas of dehiscence. The endoscopic sinus surgery nowadays is basically a medial antrostomy with removal of the uncinate process and a potential ethmoidectomy, the vast majority of the surgeries. They will sometimes go into the sphenoethmoidal recess and relieve obstruction for the sphenoid sinus and posterior ethmoid sinuses. So that said, the main thing are the areas of dehiscence around the ethmoid sinus that potentially could be the cribriform plate superiorly and the lamina peperatio laterally. It's only if they're going into the sphenoethmoidal recesses that you would worry about those dehiscence in the carotid artery of the optic nerve. Now, the other things that they want to know is the uncinate process apposed or attached to the orbital floor or medial orbital wall? There are times when that occurs, and if they're going to remove that uncinate process and do the medial antrostomy, and they rip that uncinate process and pull on it, then they're pulling on the orbital floor or the medial orbital wall, and you can have that dehiscence and then bleeding into the orbit and orbital hematoma. So they want to know about the uncinate process, whether it's just hanging free as it does 90% of the time, or is it bending over to the orbital floor or even to the medial orbital wall of the lamina peperatio. So those are the main things they want to know. Please explain question 2 again. Oh my God. Ashley, can you go back to question 2? I don't remember which one that was. Okay,
Yeah.
well, she's doing that. Are there any particular aspects of the bone involvement in sinonasal pathology that are specific or should guide our diagnosis? So I mentioned that that bony bar is a pretty typical finding of the patients who have inverted papilloma. Clearly, if you have a popcorn calcification like involvement of the bone, then you're talking about the chondroid lesions. Remember that the nasal septum is mostly cartilage, and therefore you have enchondromas, you have chondrosarcomas, you have benign chondroid lesions of the nasal septum that can occur and will point to a specific diagnosis. From the standpoint of other sarcomas, osteosarcomas, or Ewing sarcoma, no specific imaging features in that situation. The other pathology that is Typically, a diagnosis you can make is bright on T1 and an aggressive lesion in the sinonasal cavity. We're going to go with melanoma. Intracranial lesion with a cyst around the periphery, we're going to go strongly with olfactory neuroblastoma or esthesioneuroblastoma. All the other ones, the SNUCs and the other undifferentiated carcinomas and adenocarcinomas, not so much. Perineural spread, we're going to go with adenoid cystic carcinoma as the salivary gland lesion that can occur in the sinonasal cavity that has the highest rate of perineural spread, particularly into the pterygopalatine fossa. So for that, if I see perineural spread into the pterygopalatine fossa and start following the fifth cranial nerve, I'm going to suggest that this could be adenoid cystic carcinoma with perineural spread. Lymphoma, usually more of a homogeneous lesion rather than the squamous cell carcinoma, kind of bland. That would help. Can you please explain how to differentiate supraorbital ethmoid air cells from frontal? It becomes very confusing at times. I usually am able to kind of make that distinction based on usually the sagittal reconstruction, that you can see the communication of the air cells with the ethmoid going above the orbit. Same thing is true with the anode cell. So I referred to the anode cell, which is an ethmoid air cell that actually extends superior to and sometimes even posterior to the sphenoid sinus. Much better seen on the sagittal scan. For all those of you who have these questions and would like a little bit more definition, I did create a sinonasal mastery course. It's between 2 and 3 hours, gets into more of the inflammatory disease and the sinusitis and the osteometal complex, et cetera, with examples of all of these different types of cells, the Haller cell, which is the maxilloethmoidal cell below the orbit, and the named cells, so to speak, and how to distinguish them. Most of the time, the surgeons nowadays are doing a relatively minimalistic surgery. They're just trying to open the osteometal unit. So the uncinate process is taken down that allows the infundibulum and the middle meatus to drain more easily. Sometimes they're doing the partial ethmoidectomy, not all the time. And they're just trying to open the channels. Same thing with the frontal ethmoidal recess. They're just trying to open that up for frontal sinus so it will drain properly, because what they found is the more they operate and the more they take out, the more likely you've screwed up the mucociliary clearance that normally pushes the mucus in the appropriate location back in the back of the throat. And then we go and we swallow it down. So that's actually the best way, the natural way that mucociliary clearance goes. It passes it back to the pharynx for us to swallow it down. If you do too much of this operation, you ruin all the cilia and everything, then it's all distorted and you have chronic sinusitis because it's not draining properly. So a little bit more minimalistic about functional endoscopic sinus surgery these days. Please, can you explain exactly what we have to look for anterior ethmoidal artery in our report? So I don't even report on the anterior ethmoidal artery. Anyone who's doing sinus surgery endoscopically should be able to identify the anterior and posterior ethmoidal air communications. It's that little triangular thing that you see. Again, I did describe this in my mastery series course. It's the little triangular opening to the ethmoid air cells that you will see on the coronal CT scan. That is the potential source of an orbital hematoma if they nail it. But orbital hematomas are incredibly uncommon nowadays with endoscopic sinus surgery. Everyone knows the anatomy. They do 3D to guide them most often. And so they know where the carotid artery is, the optic nerve, the anterior ethmoidal artery. So it's pretty rare to nail that. Please, okay. Question number 2. What was question number 2?
Dr. Yousem, that was about pot puffy tumor.
Oh, pot puffy tumor. So pot puffy tumor, as you saw in that specific case, you saw a defect that was in the frontal sinus leading to the scalp, and it was a large inflammatory process, not a tumor, that occurs in the scalp and then presents as a soft tissue mass in the frontal region, and most commonly from frontal sinusitis. When you have pot puffy tumor, you always have to worry about potential intracranial complications, which would include a meningitis, a sinus thrombosis, and an epidural abscess.
Think
Well,
that's it, Dr. Yousem?
yeah, I think so.
Well, thank you so much for the case review and for answering all those questions you got. We appreciate it.
My pleasure. Any other
And go ahead.
announcements?
Yes, this is also the official kickoff of our new webinar series, Case Crunch Rapid Review, which are 1-hour rapid fire case reviews taking place between February and April. So if you're studying for the boards or you like case reviews like this, you can register for this series at the link provided in the chat. Hope to see you at those case reviews. Be sure to join us next week on Thursday, February 29th at 12 p.m. Eastern, where Dr. Elizabeth Arleo will deliver a lecture entitled In Preparation for Women's History Month, Screening Mammography Saves Lives. This lecture is co-sponsored with AAWR, and you can register for that at mrionline.com and follow us on social media for updates on future new conferences. Thanks again. Thank you, Dr. Yousem.
Thank you,
Thank you,
everybody.
everyone, for attending, and have a great day.
Thank you. You too.